everyone, it is Diana Slager, and I'm going to talk about cleft palate and what that type of speech sound disorder will look like in some of the patients we may encounter. So this definition came out of our textbook, and it says that clefting refers to a division of a continuous structure by cleavage, a split prominently caused by a failure of the palate to fuse during fetal development. I'm sure everybody in our class has seen images before of what cleft palate looks like. Perhaps you know somebody who has cleft palate. It's something I think that we're familiar with. But what it actually looks like might surprise you when we break down the different types of cleft that there are. So this first picture on the top is going to be, at least for me, this is what I had always associated cleft lip with. And that's clefts of the prepalate. So there's three different types of prepalatal clefts. There's cleft lip, cleft of the alveolar process, and cleft of the prepalate. When you move to the picture on the right side of the screen, the middle one, there are two classifications of clefts of the palate. And if you see there inside the child's mouth, that's more what we're referring to in palatal cleft. So that's a cleft of the soft palate or a cleft of the hard palate. The bottom image refers to facial clefts, and this is clefts that fall under any other bracket aside from prepalate and palatal. So in this image, you can see that the child does have like cleft lip. I believe in the description of this image that they also had a palatal cleft, but then if you look up by the child's eye, you'll see another type of clefting occurring. Okay, so this is a short little clip put on by a doctor that will kind of talk about different types of terminology that go hand in hand with cleft.
Hello, I'm Dr. John Mira. I'm the plastic surgeon-in-chief at Boston Children's Hospital, and I'm here today to talk to you about cleft lip and palate. This is the most common craniofacial anomaly found in children. Normally, our lips and palates fuse in approximately the third month of gestation. When this doesn't happen, you have what's called a cleft lip or a cleft palate. No one is exactly sure what causes this. There may be some genetic component and there may be some environmental. However, there is no single gene that causes cleft lip and palate. It occurs in approximately 1 in 1,000 births. There are a number of different cleft lip and palate diagnoses, and I'd like to review them with you. The first is a unilateral cleft lip. This is an isolated cleft just of the lip, and it does not involve the palate. In this lower picture, this is a cleft palate. This just involves the palate, and the lip has fused normally. This is a case of a unilateral cleft lip and palate where there's been failure of fusion of both the lip and the palate behind the lip. This diagram shows a bilateral cleft lip, and what you can see here is that both sides of the lip have failed to fuse. So this lateral tissue here and here has not fused with this central portion of the lip. Now this last case is a bilateral cleft lip and palate. So you see here both sides of the lip have failed to fuse, both sides of the palate here in front, and then all the way back into the central portion of the posterior palate.
So I felt like that was a pretty good description of the different types of characteristics that go along with cleft. And for me, I'm a visual person, so I felt like that was pretty helpful. One thing I would like to point out is he had mentioned that cleft occurs about 1 in 1,000 births. Our textbook is actually a little bit more updated than the video. The video is several years old. And so right now the statistic is that cleft will occur in about 1 out of 700 births. Some other general facts is that clefting will typically occur between the 8th and 12th weeks of gestation. Now what's very interesting is that it can occur past that point if there's any type of trauma that occurs during gestation, in which case an already fused palate can rupture, and that can lead then to clefting. But more often than not, it will occur during the 8th and 12th weeks of gestation. Now, with that, there is no one single cause for clefting. So We can't pinpoint, oh, it's simply genetic, or we can't say it's strictly environmental. We really don't know. There isn't enough information on that. It's essentially right now known as sort of like a perfect storm. So palatal clefts and lip clefts are the most common congenital anomalies. And the most significant diagnostic challenge would be the developmental aspects, which we'll touch on in just a second. The next point is kind of interesting. Diagnosing cleft is an ongoing process. So this is not something that's just, we know you have cleft and that's that. We go from there. Cleft is constantly changing due to the fact that the infant will continue to develop. And as we've learned in class, the mouth and everything developmentally, the entire body is constantly changing and growing and developing in such a short amount of time, and that's going to have an effect on what the cleft will actually look like and how it's going to affect the individual specifically. So unlike other diagnoses, cleft is a continuous situation that they're going to have to continue to address. As we saw in the video, there is unilateral and bilateral clefting, which refers to where it falls in relation to the hard palate. There are median clefts, which are just clefting that occurs directly in the midline. And then this last point is kind of interesting. So there are submucous clefts. I did not pull up a picture of these. These can be kind of graphic, and I didn't want to bombard you guys with images, but submucous clefts are known because they have an intact mucous membrane that covers the space that's left by a cleft. So if you can imagine having a cleft and then like a mucous membrane that's covering it, what's interesting about that is that because there's something covering that gap, individuals who have submucous clefts typically don't have any issues with feeding or with speech. So that's kind of an interesting little aspect. So some characteristics of cleft. As we kind of touched on earlier, there is a developmental delay. So children with cleft are typically found to have speech and language delays, just due to the nature of the beast. There are compensatory errors, and this typically comes from where the active and passive articulators are. Now, an individual who has cleft will typically alter where their articulators are due to the inadequate closure of the velopharyngeal valve. That makes a little bit more sense when you kind of look online as to like what is the velopharyngeal valve, but I'm not gonna spend 2 hours explaining all that to you guys, but that's just common, is the compensatory errors. There are phonological disorders and phonemic disorders that typically accompany individuals with cleft palate. And then there are consonant distortions as well as vowel distortions due to nasal emissions and hypernasality. So essentially all aspects of speech can really be affected due to cleft palate. And then the last fact is that there's atypical backed articulation. And this can result, backed articulation can result from attempting to capture airflow or from using the tongue to seal the velopharyngeal port. So this is a table that is in our textbooks on page 359. And I took a snapshot of this because I really thought that this was a beneficial way to see a long list of substitutions that are common compensatory articulation errors for individuals who have cleft palate. So if you look all the way on the right, that column is going to talk about what are they substituting for. So perhaps, let's say they're looking at a stop or a plosive. And then it's going to tell you in the middle section exactly what they're doing. And then on the left-hand side, you're going to see the compensatory articulation was the glottal stop. And I just felt like this was a snapshot that really gave you a comprehensive look as to how many different substitutions are occurring, how many different compensatory strategies that individuals with cleft kind of figure out and learn on their own in order to still produce speech. So that leads us to therapy. What does therapy look like? Well, at the bottom of the screen, I mentioned a point that I find to be very important to know. Most children with cleft palates will undergo palatal repair surgery by 18 months. So while a speech and language pathologist may be pulled in beforehand to deal with swallowing and things like that, our therapy will really come into effect post-surgery. So when we go into the therapy, there are typically 4 main goals when addressing cleft palate. And those goals are to improve the placement of consonant productions, to improve velopharyngeal valve function and thereby decreasing hypernasal resonance quality, to modify compensatory articulations, and to improve the child's phonological system. So that's kind of a broad look at what the therapeutic goals are, and obviously this could be a little bit more tailored depending on what the case looks like and what type of clefting is actually in front of you. And that leads us to the credits. So thank you guys for listening, and I hope it was informative.